Earlier, we are going through some of the most important yet less discussed topics from the last session. And today we are entering the concept of communication, the importance of communication. And it is indeed our pleasure and privilege to have Dr. Biju Raghavan, who is a very eminent personality and an expert in walking us through the communication topic with us today evening. So without much delay, I am handing over it to Dr. Sridevi Warrior, who is joining us as the facilitator. Good evening. For formal faculty introduction and further session facilitation. Ma'am, it is over to you.
Thank you, Sripriya, and thank you all the participants for joining us on time. As she mentioned, today we will be dealing with a little different topic, that is communication skills, but that is the most important topic in the whole training session, I must say, because everything starts from good communication. Even the symptom assessment, management, managing a patient and family, everything starts with good communication skills. And we have Dr. Biju today as our faculty. He's a senior consultant and head of Department of Pain and Palliative Medicine in a hospital in Kochi, that is Rajgiri Hospital. He's also a faculty member for many of the training programs across the country. And specifically for communication skills, end of life care and ethics are one, I think, among the most common topics that he dealt with. And he has more than 17 years of experience in palliative care as a teacher, as a doctor, and as someone who is heading the department in the hospital. Thank you, Dr. Biju, for being present for the session and sharing your knowledge with the participants.
Thank you, Sridevi and Sripriya. I am unfortunately not able to project my voice as much as I would have liked to. Not very well. So I don't know whether you can hear me properly.
Yes, sir, you are audible.
Right. Otherwise, I might consider putting in the earphones, and maybe if I'm audible, then that's fine. Yeah. So thank you again, both the Sri Devi and Sri Priya and Palim India for inviting me. And thank you all of you who have joined from all over the place online for today's session. And if with the permission of the chair, I might start the program. We have a lot to cover. All right, I'll try to share the screen. So today we are going to talk about the basics of communication skills and why it is important, because there was this study, it's a very old study, way back in 1986. It came in the, what do you call it? It was a study on headache. And it came in the Headache Journal. And what they found out was the best predictor for resolution of headache turned out to be the patient's perception that they have been listened to in the very first meeting that they had with their doctor. So we often think of communication skills as something to do with human relationships. Of course, it is a lot to do with human relationships, but as medical practitioners, we need to understand that communication skills has a great impact on the clinical outcomes that we are looking for. So most of the time when we are trying to diagnose a disease or treat a disease, we are not really thinking in terms of adding communication as our arsenal to get the best possible clinical outcome. But this study shows that communication skills has an impact on clinical outcomes. And as clinicians, probably this should interest you in the importance of communication skills. Apart from that, a lot of medical errors can be taken care of, and most of these medical errors are completely preventable. It can prevent harm to the patient. It can prevent harm to us as medical practitioners. It may reduce, the reasons why we get sued in court. Good communication skills is supposed to protect you from harm, physical harm, psychological harm, financial and reputation harm. And that is also a good reason to improve upon the communication skills that we have. And we understand that communication skills are a very, very dynamic process, because it has an effect on your diagnostic accuracy. It also means that you may have a very good plan, management plan for your patient based on your knowledge and skill. But if your patient does not comply, you're not going to get an outcome. And the reason why your patient may not comply could be anything. It could be a financial reason. It could be it could be a socio-psychological reason. It could be anything. And until and unless we are not aware of it and we don't do something about it, we are not going to get our patient comply with the best treatment options that we have given them. And if you don't have a complying patient, you're not going to get a clinical outcome. Therefore, for your best clinical outcome, you need to ensure that your patient is compliant to your management strategy. Not just your patient, their family as well. And there also communication skills should help you. And if you have a compliant patient, you can expect a clinical outcome that you were looking for. After all, what is evidence-based medical practice? You are expecting a clinical outcome from whatever your management strategy has been. And on theory, the science of it may be perfect, but in practice, it will not happen if it doesn't get done. Really, it doesn't get done practically. And for that, when your patient complies with your management strategy and they get a good clinical outcome as was expected out of evidence-based medical practice, then you have a happy patient and a happy family. And if you have a satisfied patient and family, you have a happy medical team, as opposed to a patient and family who are always cribbing and getting angry and not satisfied with you and your team, and that is going to put stress on you as well as your team. And just the opposite, when you have good outcomes and the patient and family is happy, you and your team will be happy, they will be less stressed. And just repeating the point on patient safety is, remember, your safety and your team's safety, and therefore less chances of litigation. And in our in our country and in many other cultures, there is instant justice, like Maggie 2 minutes noodle, instant justice, where the mob attacks the healthcare professionals because we don't have patience, time, energy, or money to go to the legal system. And many a times, what the legal system provides may not be satisfactory to the party concerned, and hence the growing prevalence of instant justice. Therefore, building up relationship, getting the best possible outcome, having a satisfied patient and family, all leads to a win-win situation for us. Because good communication skill should save us time, energy, effort. I repeat it, it should save us time, energy, effort. It should get us good clinical outcome and should provide safety and also material benefits in terms of better revenue for us and our institution. So all of these things are what we are looking for with good communication skills. And basically we improve our communication skills for our own selfish interest. And as a result, we may do some good to the patient and family and to society at large, but primarily we learn good communication skills for our own selfish interest. Now, that is something that I want to emphasize again and again. Now, what does this involve? Today, our session is learning the basics. And the basics of any communication, whether it is diagnostic communication or therapeutic communication, whatever it is, the basis, the foundation of good communication is active listening. Active listening leads to successful relationship. That is what communication is all about. And the foundation being active listening, we will break down what active listening is all about. So for today's session, to keep it simple, I have divided into two sections. One is body language, or technically called non-verbal communication, and second is the verbal communication. So why do we need, as doctors, why do we need, or as healthcare professionals, why do we need uh, to learn these skills? Because most of the time when we are interacting with people, we are not aware, consciously aware of what our body is communicating. What are we conveying through our eye contact, through our facial expression, to how we are positioning our body, everything, our gestures, everything. And oftentimes, since we are not aware of it, we may be saying something, but non-verbally we may be conveying something else. This can lead to confusion on the part of the patient and family. It can lead to dissatisfaction on the side of the patient and family. Therefore, to align what you're saying verbally as well as non-verbally is very important. Secondly, it is the major component of any communication. Major component of any communication. No matter what language you speak, no matter what region you come from, no matter what country you come from, no matter what is your ethnicity, doesn't matter what all our differences are. Inherently, as human beings, we all share some very often, very common non-verbal communication. And apart from that, not apart from that, it is universal. It is also the major component of any communication, not just professional relationship, any human to human interaction. Now, please understand that patients and families don't come to us because they want to come to us. They come to us because they are sick, they are not well, they are ill, and therefore they are forced to come to us. The starting point itself is negative. We would rather spend that time going to a movie or going to a hotel restaurant to have some good food, or maybe a resort or a holiday, and spend that money on things we would value. But getting sick, getting injured does not come into any of those parameters. Therefore, since the starting point itself is negative, the patient and family are already in a negative state of mind. They are stressed. They are not in the best frame of mind when they come to us. And therefore, in the healthcare profession, the starting point of our human interaction itself is negative, which is unlike most other industries where human to human interaction is it's a transaction which one looks forward to. For example, if you go to a shop, you look forward to buying something and you pay for it. If you go to a restaurant, you look forward to having an experience over there. If you're taking a holiday, you're a tourist, you look forward to it. But as I might have conveyed what I'm trying to say. Therefore, it is very important to align what you're saying with what you're conveying non-verbally, because this is one field where we start with a negative and we have to make it a positive experience for the patient and family. If one word I can use over here is satisfaction. We have to provide satisfaction as professional caregivers to our clients, which are the patient and family. And remember why we are doing this: for our own personal uh, interest, for our own uh, special interest, because we don't have time to waste, we don't have energy to waste, we don't have effort to waste. We need to get good outcomes as early as possible. We need to be safe. Therefore, we learn all of this. Always remember that why we are learning communication skills. So coming to the positive body language, it is like a huge ocean. Obviously, we cannot cover anything much in today's session, but I've just taken out around 6-7 important points, which I thought would be a good start for all of us. You're most welcome to Google body language for doctors. There's plenty of resources available, and you may, if you're interested, you may, keep improving yourself by, reading those matter. Or if you can, if you don't want to read, you can go to YouTube and check good body language for doctors. There are plenty of short videos on that as well. So today, just some important points that I thought would be fundamental to what we are trying to achieve here. First and foremost, eye contact. When your patient and family comes into your consultation room, make sure that you make eye contact with them and show them where they have to sit. And if you need to go through their documents either on the computer or hard copy, you can do after that. You can tell them, I just give it 1 minute, let me go through this. Or better still, you can, if possible, go through it and then ask them to enter. Depending on the situation that you are dealing with, if you are working in a government hospital, which may be overcrowded, you may not have the luxury. But the point is, the first thing is to make eye contact, because if you keep looking at the document and not at the patient, that is going to reduce satisfaction. Any human to human contact starts with eye contact, and therefore it is the starting point of any relationship. And we want to make good relationship with the patient and family for our own best interest. The second point is to smile. And we may think that what's a big deal to it? We are all, nice people. I mean, what is there to learn about it? Remember, we, as human beings, we would naturally smile at people we like and we know. We are unlikely to smile at people we don't know. And therefore, without we being aware, it is a lot much possible that we are not smiling at our patient and family members. And it is not our fault. That is a normal human nature. But there are many industries, many human to human interaction specialities where you are actually taught. For example, the hospitality industry. When you go to a hotel, the person at the gate, the security person smiles at you and welcomes you in. The person at the reception smiles at you. At every point, you are made to feel welcome. If you go to a business house, you are always made to feel welcome with a smile. But that may not be the case. That may not be the experience that our patient and family has when they come to the hospital. The security person may not smile. The reception person may not smile. The person outside your OP who ushers in patient may not smile. You may not smile. You may smile. I don't know. But smile is a rare commodity in our healthcare sector. And therefore, it is important to learn what we call as a professional smile. It is not a false smile. It is not the normal human, the smile that comes, but it is a professional smile. It is a skill that has to be developed. It is just like how you learn to check your BP. The first time you saw a sphygmomanometer, and you were taught how to tie the cuff and how to check for systole and diastole, and then you practiced, and then you got good at it. Same thing with a professional smile. You have to practice it. It doesn't come otherwise. And how do you practice it? You can start practicing at a safe environment, and the safe environment for you would be your own hospital or clinic area. And when you start from home, you remind yourself that you are going to smile at the security person or the catering person or the ward boy or the cleaning lady or your colleague from other specialty, or the nurse, or the physiotherapist, or the pharmacist, or the people in the administration. You make a conscious effort. You think. It's a cerebral activity. You think and then you smile. You're not looking for outcomes here. Sometimes you may get a smile back in return, or you may get a very surprised blank look in return, or a puzzled look in return. But please remember, you are just practicing professional smile, because what is the ultimate aim? Ultimate aim is that a smile will come to your face as a spinal reflex, ultimately. Just like now you can check a BP as a spinal reflex. You don't have to think how you were taught in your first physiology labs session. You don't have to think like that. You can check BP while thinking of some other things. You can do 2 or 3 different things, and meanwhile you can check your BP also. The same thing. So that comes with practice, and that will not come without practice. It is a skill. It's a professional skill. Many industries, the airlines industries, the business domain, the hospitality sector, all the areas where all the service industries which deal with human beings have this skills that are taught to people, except the healthcare industry. And it is something that we think it is a small thing, but across the world there is only one universal meaning of a smile. That means you are welcome, and I'm not a threat to you. I'm here to help you. All of these are important messages that your body is sending out to the patient and family. It improves their satisfaction. And another important area is the tone of voice. Remember, it is not always what you said that creates the problem. It is often how you said what you said that creates the problem. And therefore, if you promise that you will practice the professional smile, I can guarantee you, it is like you go to a shop and you have buy one get one free. I'll give you this offer. If you promise to practice professional smile, a good tone of voice will come to you free. You don't have to make any effort. Why? Because with a smiling face, you cannot have a grumpy voice. You cannot have an indifferent voice. You cannot have a hostile voice. With a smiling face, you can only have a good voice, a good, warm, welcoming tone in your voice. And that takes care of a lot of trouble we get into from time to time. And it is very important for us to understand that a warm smile and a warm tone of voice is a protective skill. It protects us from a lot of trouble. It soothes the anxiety, it soothes the frustration, it soothes the anger, it soothes our patient and family a lot. And in that sense, it is in our best interest to stay safe, to not let our patient and families get frustrated and angry. So a lot of things we can manage by these two things. Another area is how you position yourself when you are interacting with the patient and family. Here on the upper left side of your screen, you see a healthcare professional standing by the bedside of the patient. And you can see the patient is trying to make an eye contact. The healthcare professional is also making an eye contact with the patient. So eye contact is very important. However, you can see the eye contact is not at equal level, right? It's not at equal level. This is creating the hierarchy situation. And hierarchy is not very comfortable it's not satisfactory when it is not satisfactory in our interaction. So You can see here on the right side, here is the healthcare professional who is sitting, and therefore the eye contact is more at level. It is not going down, it is more at level. And that is something that we need to understand. In the healthcare sector, when a patient and family comes, they need us. So they are the needy people, and we are the providers. And therefore, it is not a relationship among equals. The healthcare professional is always a superior inside the healthcare system. Now, you need not be a doctor. If you're a nurse, you're a physiotherapist, the ward boy, the catering person, or the administrative person, doesn't matter. In the healthcare system, we are powerful because the patient and family are the needy. We literally have their lives and their well-being and their comfort in our hands. Therefore, no matter what is their position, their social position outside the healthcare system, inside the healthcare system, uh, the people who are entering in the waiting in the waiting room, am I supposed to admit them, Priya?
No, sir, we are taking care of that. You
So
please continue with
it
the
keeps
thing.
popping up. So can you please take care of that?
Sure, sir. Sure, sir.
So basically what we need to understand is within the healthcare system, we are very powerful, and hierarchically, we are above the patient and family. However much we say the patient is the center of our universe, etc., etc., in real, for all practical purposes, hierarchically, we, the healthcare professionals, not from the security person to the topmost doctor or the MD of the hospital, whoever it is, we are hierarchically above. And no matter what is the social position of the patient and family outside the healthcare system, they may be much above you in the outside world, but within the healthcare system, they are always below you. So therefore, when we align our eye contact at level, that reduces the hierarchy. So basically, how you position your body in relation to the body of the patient and family will determine satisfaction. Because when you create equality by reducing the gap between the eye contact, you create equality. So this would be more satisfactory for the patient and family because you're sitting down. This would be comparatively less satisfactory because this enhances the hierarchy of the eye contact, right? So if somebody is sitting, if you are sitting and somebody is standing in front of you, there also the hierarchy, even though you're sitting below, you are staring upwards, you are creating the hierarchy that I am a powerful person and you are a less powerful position. The moment you offer a chair and that person sits, the eye contact levels and it creates equality. And in non-verbal communication, equality of eye contact improves satisfaction. Inequality of eye contact reduces satisfaction. And we in the healthcare system, within the healthcare system, are always hierarchically above the patient and family. And the more we create the gap within the eye contact, less satisfaction. The more we equalize the eye contact, more satisfaction. Therefore, when we go to a patient's room, even if you're spending total of, let us say, 2 to 3 minutes, that includes talking about how you are and then doing a little examination, etc., etc. At least if 50% of that, at least the talking part, if you can do by sitting, it will enhance their satisfaction. Another thing that you can consider is look at this person trying to make eye contact and look at the sternocleidomastoid of this patient. It is so taut because this person has to turn the head at an acute angle to talk to this healthcare professional. So when you enter a patient's room, you can initially position yourself nearer to the foot end of the patient. That is the point when you say, hello, how are you, how are things, etc., so that the patient can make eye contact without making an acute angle of his head. And that will be comfortable for the patient. Look at this healthcare professional sitting near the foot end of the patient so that the patient can make a comfortable eye contact. So there is not only leveling of eye contact compared to this, it is also making comfortable eye contact because the healthcare professional has positioned himself in this picture nearer to the foot end. Of course, then when you need to examine, you need to palpate, percuss, etc., you can move forward, or if you need to do a procedure, you can move forward or backward. Whatever is required, you can do. But the initial part, when you enter the room and say, hello, Mr. So-and-so, how are you today? And, how has the night been? How is your pain? Etc. Whatever the verbal part of it, if you just sit down, pull up a chair, pull up a stool, or even if with the permission of the patient, the bed of the patient, a small section of that, uh, provided it is neat and clean, not contaminated with human any contaminant, make sure that you are safe also. So anything and everything is okay, and position yourself near the foot and sit down and have this interaction. Remember, the other members of the team, they are trying to blend in the background, because if you're going as a group, it should be clear who's going to be the primary communicator. And the primary communicator is the person who should be primarily making eye contact with the person. There should not be distraction in eye contact. So the other people who are part of the team may try to blend in. If you see, this photographer who took this picture is outside the purview of this patient's uh, gaze. So the photographer is somewhere here. So similarly, you can blend in the background. You can sit down, or if you don't have a place to sit, you can try to blend as much in the background as possible, so that the communication between the patient family with the primary communicator or the healthcare professional is not interrupted by other healthcare professionals. When it comes to children are smaller in size than adults, and therefore it is very often that we as adults bend down and look down upon them, literally. And I don't mean figuratively, I mean literally, we bend at the hip and look down upon them. So they have to look up, we are looking down, and the same principle of hierarchy comes in. And in this case, children get scared, and it becomes difficult to build up a relationship with children. The more the less scary option would be if you would again just sit down, and so that your eye contact is at level with the child's eye contact, so you would appear less scary. And if you are planning to sit by the child, to reduce the child's fear of you, you can introduce yourself. You say, I'm Dr. So and so. I came to see you. Can I sit down here? And then the child may, of course, unlike an adult, the child may not be able to reply to you like an adult, but the child may smile or may feel embarrassed, but whatever, but that will reduce the fear of the child if you introduce yourself and take permission to sit down by the anywhere near the child. In this case, we have a healthcare professional who is at his knees. Can we have the disturbance being taken care of?
Can you please unmute yourself? Sripriya is getting unmuted every now and then. Can we just keep her in the waiting room so that the session is not interrupted?
Sure, I'm doing that, and I am also enabling disabling the option to participants to unmute themselves, so that now they should request to unmute themselves, ma'am. Doing both.
Excellent. So moving on, so this is the important about how you position your body in relationship to another body, that is the patient and the family. Try to position yourself near the foot end initially, then move on if you want to do a procedure or an examination. And instead of standing, try to position yourself in a sitting position, because it will reduce the hierarchy, it will equalize the eye contact. And when children, the same thing applies. It reduces their anxiety vis-a-vis you, and it help build up a relationship. And if children are happy to see you, well, and the patient is happy to see you, well, I can assure you the family will be happy to have you around. And that is a good way. It is all for our own selfish interest, because we want to get good clinical outcome and as well as to stay safe. Another important area is how we, earlier was the body position, now is the body posture. If we are sitting back, it conveys that I own this place, I am the Lord and Master of my universe. I will think about it if I have to help you. Whereas if you're sitting with a little bit of a kyphosis, a slight bent forward posture, whether it is standing or sitting, it conveys I'm here to listen to you. I'm here to help you. Now, if you would go back to your student days, that is the usual posture we adopt when we are sitting for our external viva, or for that matter, any viva during exam time, because we are conveying that I am here to listen. And the same thing, but when we become doctors, or the more senior we become, and sometimes we unknowingly adopt postures of power, that is the lordosis. And lordosis conveys a message which is not very positive, whereas kyphosis conveys a message which is very positive. So your body conveys, even when you may be listening. So if you are leaning back into the chair, probably that lordosis may be conveying, oh, I am bored, or I am disinterested. You may not mean it, but that is what is being conveyed, and that is what is being perceived by the person sitting in front of you. So we may not realize it, but that is what happens. And that reduces satisfaction, whereas a bit of kyphosis improves satisfaction. And when we start any interview, whether it's a 2-minute interview, or a 15 minutes interview, or a half an hour interview, depending on the complexity of the matter we are dealing with, always start with a kyphosis, because when the patient and family comes to you, or you go to the patient's room, if they are IP, always start with the kyphosis in the posture. And you would notice that at some point of time, if it is a longer conversation, it's a longer interview, at some point of time, the patient or the patient party may move back into the chair or wherever they are sitting. In that, the moment you notice, you also move back a little bit. And after some time, it's possible that they move forward. And then when you notice that, you also move forward. So you have to be not only aware of your body language, you have to be aware of the body language of your patient and family. And that is possible. It is not a big deal. It's just a matter of practicing a skill, and it comes with practice. It is not a talent. It is just a practice. And when you do that, it is called what we call mirroring. Basically, you're mirroring the body movement of the other person. So that person starts with kyphosis, you start with kyphosis, that person move back, you also move back, then the person moves in, you also move in. So this basically what your image does on the mirror. When you go near the mirror, your image comes near to you. When you go away from the mirror, your image goes away from you. The same thing, that is why it is called mirroring. There's a psychological aspect to it. When you mirror somebody's body posture, you become likable for them. There's a lot of psychology science behind it, but we're not going to. Just please remember that you improve the satisfaction level of your patient and family by doing it. And if you don't remember, doesn't matter. At least remember to have maintained this kyphosis posture, that also improves the satisfaction of the patient and family, because they feel that you're here to listen to them. So these are some of the examples. You don't need a full-fledged bending like the old previous Maharaja logo of Air India. I don't know whether you're aware of it, but people of the older generation would remember that. I'm just saying that a little bit of kyphosis goes a long way. It need not be a whole spine. It could be just a cervical kyphosis, a little bit of thoracic kyphosis, a little bit of kyphosis at the hip level, anything. But a little bit of kyphosis goes a long way in improving the satisfaction of the patient and family. Another area is respecting the body space, because oftentimes we, as medical professionals, we have to touch our patients, and that is unnatural for us, because usually we allow only those who are very intimate with us, very close members of the family, friends, and maybe some relatives. There's a small segment with whom we are comfortable, with whom we are intimate, and we are okay. We actually look forward to them coming and being very close to us, touching us. Then there are a lot of people we are familiar with, we are social with, and we adopt a distance, let's say a little bit away from the intimate zone, but not very far away. That would be the social zone, maybe within a meter from our body, within that circle. And that's where, but that's the distance we adopt when we as colleagues are interacting, or uh, people with whom we people whom we know, we are socially connected. Then there are other people who we don't know, and that we automatically maintain a little bit more of distance. Now this comes naturally to all human beings. This becomes a problem when we are in a crowded place, for example the lift or a public transport. Then it becomes uncomfortable, and therefore we sometimes tense, we just fold our arms, and we do a lot of things unconsciously, because it is uncomfortable to be standing very near to people we don't know. And the moment the lift opens, we are trying to get out of that place. So therefore, when it comes to the patient coming to us, the problem is that even though there is an implied consent, they came to us. They know that they will be examined. There's inspection, palpation, percussion, auscultation. They know about it, but that doesn't mean the emotional discomfort of somebody invading your intimate space, that still happens. And for that, we have to understand that that is real, and the way to reduce that emotional trauma is to forewarn them. For example, if you want to auscultate them, you just take out your step and say, I want to examine you. Or you can say, may I? Or you can just say, let's see how things are, or whatever is convenient to you. But at least you give them a head start. You tell them, so they have this even a momentary head start that you are going to touch them. So without saying a word, without telling them what you're going to do, suddenly you start touching them, auscultating them, take off their clothes and start palpating their tummy. They are going to be very, very uncomfortable. And if we are going to examine more intimate spaces like the anal area or the vaginal area, or any of the urethral area, or any of those kind of areas, it becomes even more distressing. So for example, if you need to put in a Foley's catheter, you tell them this is what needs to be done. And like the way you watch cricket, along with the video, you also want to hear the commentary, because that is satisfactory. Similarly, when you're going to put in a Foley's catheter, you do a running commentary so that they keep getting a head start on what is going to happen next. You tell them, okay, once you told them this is the procedure you're going to do, and once the person is lying on this, then you start, okay, I'm just going to clean this area with some antiseptic. It might feel a little wet, a little cold, but then you say, okay, now that is done, I'm going to put a cloth over you, and please don't bring your hands over this area. You can try to be comfortable by putting it and keeping your fold your arms under your head. Okay, and then okay, I'm going to put in a jelly into you. It might feel a little weird, uncomfortable, but this is to make you when the tube goes in, you will be comfortable. So I'm going to put in the jelly. Then you put in the jelly, and then you say, okay, I'm going to arrange my things. I'll just leave the jelly in there so that it works. Meanwhile, I'm going to just get things ordered in the tray. You might hear some clanging sounds and things like that. Don't get scared. So then you get your tray arranged and put everything in place, and so that you are giving some time for the jelly to work. Then you start, okay, now I'm going to put in the tube. And then you just do this thing. And once that is done, you just inflate the balloon and say, okay, now that part is done. And I'm just going to finish up. My assistant here is just going to, the nurse here is going to just clean you up a little bit so that you're good to go. And then you leave. So while you have done it, you have always given the person a little head start in his mind as to what is going to happen next. Otherwise, everything you do will come as an unanticipated, anxious experience for the patient. And overall, the satisfaction will be very, very low, because every moment in that treatment room where you have been doing was a very terrifying experience for that person. And there is one example of a well-meaning healthcare professional leaning forward in an aggressive way, a hyperkyphosis, and look at this person who is trying to lean back as much as possible into his chair, and the look of anxiety. So this is not what we are looking for. What we're looking for is here. This is my palliative head nurse, this is pre-COVID time, and hence no mask. And look at this picture. Everything we talked about till now, it is here. You have the eye contact, you have the smile, both people are sitting, so the position is there, a slight kyphosis of the neck over here and here, and a comfortable distance between these two. And this is what we are really looking for. And of course, we can't hear the tone of the voice, but I can assure you the tone of voice was very congenial over here. So these are the few things that I thought I will share with you. But again, the last but not the least, a human touch. I always encourage people to have a human touch, because as doctors, it is very, very important, because the most the most powerful therapeutic tool that we have in our arsenal is our human touch. And as a regular practice, whenever I go and see patients, either in IP or in OP, at the end of the interview, I always extend my hand for a handshake. And my experience is that the patients will grab my hand with both their hands, because there is such a deficiency of human touch that when people get it, they will grab it with both their hands. The other area of where we can touch is on the shoulder, but please remember, do not pat. Patting is paternalistic. You can only pat down somebody who is less lower in the hierarchy. You cannot pat somebody higher in the hierarchy. You cannot pat your boss or the dean of your institution and say, oh, madam, I'm very proud of you, or sir, I'm very proud of you. You can't do it. You can only pat down, and therefore it is paternalistic. And we are encouraging equality in communication, because that is where the satisfaction is. So instead of patting, a touch on the shoulder will work better, if not equally well. And so please remember, touch is very, very important. It makes a day for the patient and family. They will keep saying, that doctor, it touched me and consoled me and touched me and encouraged me. So that especially coming from the healthcare professional, patient and families are really, really appreciative of the human touch. Now, I took time in the non-verbal segment because I really wanted to emphasize, because even though they are universal values, they are the major component of any communication, but are very much less understood and less explored areas of our skill set. Therefore, I took some time. So I'll not be spending too much time on the verbal do's and don'ts. So let's focus on that. One, your pain is now better, isn't it? So after surgery, we are going and seeing the patient, and we ask something like that in a tone where we are asking for an answer that we are looking for. That's the leading question. You're feeling better now, isn't it? Instead of that, if you ask, how are you today? That is an open-ended question. And then the patient will be able to tell you. Remember the hierarchy, and if there is a very, very empowered patient who is a big person outside the healthcare professional may still say, no, I'm not good, I'm not feeling better. But by and large, people will find it very difficult to say, no, I'm not feeling better. When you ask, you're feeling better now, isn't it? So therefore, always ask an open-ended question, how are you today? And that will be good enough. Or what if they come to the OP just asking, okay, how can I help you? What brings you here today? Or whatever. Or tell me anything. An open-ended question is going to get you more information. And remember, information is power. If I have a toothache and I'm making a song and dance about it, and I come to you and I'm saying I'm so worried, this is my toothache, everything. So when I'm making a song and dance about a toothache, which according to you is a small problem, and if you tell me, why are you worried about such a small thing as a toothache, why are you behaving like that, then I will not like you. Because understand that for each one of us, we are all ultimately egocentric. For each one of us, our problem is the biggest problem in the world. And therefore, if you try to minimize my problem, you may try to do it with my best interest in your heart. You may be trying to console me, but when you do it, what you're doing is you are not acknowledging that I have a problem, or you are not acknowledging I have the problem as big as I feel it is, because it's about how I feel. And therefore, when you minimize it, you are not satisfactory to me. I don't like you. So don't minimize my problem. And if you say, oh, just a toothache, you go to the regional cancer center, the pediatric cancer ward, and you will see what real pain is. I don't care. Because, again, as I said, we are all egocentric people, each one of us. That is normal for a human being to be egocentric. That is our survival mechanism. So if you say somebody else has a bigger problem compared to you, you may be trying to console me by trying to tell me that, comparatively I'm better off. But that doesn't help, because you are saying that your problem is not worth that much than compared to other person. So never minimize anybody's problem. However small it appears to you, for that person, it is the biggest problem in the world. And never compare your patient's problem with any other real or hypothetical situation, because that again will be unsatisfactory. Instead of that, when patient comes to me with pain, and I ask them, how long have you been having this, and how much is it? Is it mild, moderate, severe? And let's say if somebody says I've been having it for 2 weeks, and my pain is moderately severe, and it is now 7 out of 10. I just say a word. You have been suffering a lot since 2 weeks, and that really gets them, the patient and the family. Sometimes the patient is so much, sometimes they start crying, because many a times the patient says that here is a doctor who understands me. Here is a doctor who really listens to me. And it is even amazing when it comes to chronic pain situation. Patients with 10-year pain history, 15-year pain history, they come and talk to me, and it's okay, this situation. And I say, how have you been managing? How have you been living your life with pain like this for so many years? And most of the time when I say something like this, they just break down and they say, this is the first time doctor has spoken to me like this. This is the first time there's a doctor who believes me. So the question that goes into my mind is, why should I be the first doctor? Why isn't every doctor acknowledging the suffering that our patient and families are going through? And seeing that it is normal for patients and families to behave in a certain way. So, you accept it, you acknowledge it, you normalize their experience that, this must be terrible for you, because for them it is terrible. And we also normalize by saying, okay, this is normal that anybody in your position would feel this way. Instead of saying, your response is abnormal. So we are not normalizing the medical problem, we are normalizing the emotional experience of the problem. And we acknowledge that they have this problem. I don't know whether it just got complicated, but I just gave you a couple of examples. And when I say, this must be terrible for you, how are you dealing with it? And how are you managing with this kind of, you must be suffering a lot. So a few words like that, it really changes the whole impact. They really get attached to you. And that is something that we really should get hold of, because that has an impact. When the patient realizes that I am there for them, then the compliance improves, outcomes gets better, and it also adds to safety for me. I'm not saying that safety is guaranteed, but at least it improves. And this is another area. Sometimes, not sometimes, often I have to deal with patients, unfortunately, who have advanced medical conditions, not just cancer, many advanced, renal conditions, CKD, advanced, most of the advanced organ, let's say also advanced cancer, where the patient has been told by the doctor that right now we will stop the treatment, and you go and eat better and become healthy, then we can restart your treatment. Now the fact of the matter is, the patient is in such poor health, not because the patient is sitting in satyagraha, not eating, it's not fasting, and hence the health deteriorated. The person's health deteriorated because of an incurable, progressive, advanced medical condition. And when you tell the patient that, you get better and then come back to me, you eat better, improve your health, and then come back to me, and the logical question that should come into our head is, how is this patient going to get better if the reason the person's general health deteriorated is because of this incurable, progressive, advanced medical condition, and the reason this person is not eating is because there is no appetite, and the reason this person's general health has deteriorated because the weight loss is there, the fatigue has increased, which is emblematic of the anorexic excess syndrome, which I hope most of you are aware of, if not easy to find out these days. So in debility of age, with progressive advanced medical conditions, these are the natural ways the general health goes down. And if you tell them that you eat more and get better and then come back, then we'll restart the treatment, then what happens? Then the patient may force feed in this desperate hope to improve the health, when it is not going to happen. Or the family may start force feeding the patient. The patient may protest, I can't eat, and may end up with aspiration pneumonia and all kinds of things. And many times we are not able to tell the patient the truth, and hence we lie to them. And it is important to give hope, but it is not a good idea to give false hope. Always give realistic hope. And realistic hope, an example that I can share with you, because many a times that patients are sent to me from various specialities with incurable, progressive medical conditions. not just oncology. And many a times I have to tell the patient and the family, sometimes may not be the patient because the family has not given permission for that, but at least where possible the patient and definitely with the family, I tell them that the disease is incurable, it is advanced. So that part, nothing much can be done about it. But at the same time, I assure you that we'll take care of the suffering, that he should not suffer for however long he is there, and that I will be there for you. And most of the time, and this is not the script that I say all the time, it varies. Basically, I'm just trying to convey the message that I tell them that the disease, that you can't save the person, you can't save the person from death, but at the same time we can ensure that you do not suffer as long as it is required, as long as it is needed. Now that comes with my training in palliative medicine, because I know as a professional, I can keep a person comfortable till the last breath of their life, irrespective of their diagnosis or the stage of the disease. It may be a curative medical condition, it may be a chronic medical condition, it may be a terminal medical condition. But as a palliative medicine professionals, I can keep any of these sections of patients comfortable as long as it is required. Post-op patients, patients with many kinds of infections, herpes zoster, or any kind of ENT infection, dermatology infections, different kinds of curable medical conditions, chronic medical conditions, as well as terminal. Now, the point that I'm trying to convey is we should always give hope, but it has to be realistic. So the message I convey is, even if you can't be saved, we will ensure that you do not suffer. And that is a realistic hope. And you know what's the response I get in Malayalam? They say, doctor adu ketta madi, and നമുക്ക് ധൈര്യം വന്നു. And in translating, they say, doctor, that is all that we wanted to hear. Now we feel some courage, we feel that, because many a times, please understand, the fear is not about dying, the fear is the suffering associated with dying. And when you give them this realistic hope that that suffering will be taken care of, you don't have to suffer at all. And we tell them, in palliative medicine, we are focusing on life. We are making sure that you have, every day you have the best quality of life, so you can do what you can enjoy. It may be days, it may be weeks, it may be months, or it may be more. You can get your things in order, so many things. There are positive, and I also quote them a study which came in Journal of Oncology. I don't remember exactly when it was, but stage 4 lung cancer, there was a study on it. So there was one arm with the appropriate cancer therapy for stage 4 lung cancer, another arm where the appropriate cancer therapy along with palliative care, and they checked out what was the outcome. And they found that on average, the arm which got palliative care along with the standard oncology care, they lived 3 months on an average more than the other arm. So and now I'm just marketing palliative medicine. My apologies. In palliative medicine, not only we improve quality of life, we also improve quantity of life. So you live better and you live more. It's win-win for everybody. So when we convey all of that, we are sending people back home with realistic hope that they will be taken care of, their physical comfort, peace of mind, as well as longevity. And therefore, giving realistic hope is important, but never ever give false hopes. How's your pain? It is better. How's your breathlessness? It is better. Do you have satisfactory relief? Not really. So when patient says that the pain has reduced, or the symptoms have reduced, or they are better, do not straight away assume that all good. Just ask this question, because remember, we are in the business as healthcare professionals to diagnose disease, to treat disease at the same time, ensuring that their experience of our services, their experience of us is satisfactory. So this question, in Malayalam, I say, Vedaniki Triptigarayata Ashwasam. So Triptigaram is something that I always underline. Satisfactory. So whatever language you are talking to, and make sure that you start using this word. Do you have satisfactory relief? And if not, then we can work on that, because that is what we want to achieve. So when patients are having satisfactory relief of whatever they came to us for, they are going to go away as satisfactory clients. So hence, now focusing only on physical symptoms, also make sure that do not assume when they say that they are better. And I always tell a story where when I was doing my PG, there was this patient who had initially come with jaundice, seen by the gastro, and they found that he had a obstructive jaundice, and the reason for that obstruction was malignancy. And then the patient was handed over to the oncology, and the oncology found out that it was really a fairly advanced stage malignancy, and the patient also had cirrhosis, and there wasn't really much that could be done. And then they called in us, the palliative care team. And since I was the PG, I went to see the first person to go and see, and I was all alone. And when I went to see this patient, he was in a 3-bed cubicle, I think, and he was not there in the bed. So I went to the nursing station and I asked, where is this patient? And the nurse said that he must be at the end of the corridor watching TV. And she said that she'll go and call. So the nurse went and called, and I could see this chap coming towards me on the corridor. And as he approached me, he had a big smile on his face. And we both walked in, and he sat on his bed and he said, I am Dr. Biju. I take care of pain and all of that things. Because many times people don't understand what palliative care is. So I take care of pain and other things. And the moment I introduced myself as I'm Dr. Biju, of course I had the step, he knew I was a doctor. But the moment I said I'm Dr. Biju, I take care of pain and other things, he said, doctor, I know everything. The problem is in my liver. And my case is gone. He showed like this. And whenever I'm taking offline sessions, I ask people, so what are your comments? And people sometimes say, well, he has come to terms with his own mortality. He's very brave. Some people say he's actually very depressed, but he's just showing, that he's okay, he's nonchalant because he's smiling. And people say that, yeah, when he understands his days are numbered because he has an advanced cancer. He's just, he's accepted everything. Some people say he's just showing he's brave, but actually he must be terrified inside. So all this kind of comments I get. And the question was, what is your comment? So people could have asked anything. Rarely does it happen that somebody says, I don't know, I will ask this person why he said what he said. And so that is what, not assuming, because in my real life experience, this is exactly what I did. Not because I'm somebody special. It is because I got trained the right way. So instead of assuming, I asked him, why did you say that? Remember, we smiled, we walked into this thing. I introduced myself, and he said, doctor, I know everything. The problem is in my liver, and my case is gone. And I asked him, why did he say that? And he said that in my good days, I used to drink a lot, and therefore there is some pus in the liver. So he had no idea about the end stage cancer. He had no idea about the cirrhosis, etc. So now, if I had asked him, so when did you know that you had got cancer? And so that would have been a terrible thing, because he would not have been mentally prepared to something like that. He might have assaulted me, or he might have jumped off the window and hurt himself. I don't know. But remember, words can cause damage, it can cause emotional trauma, it can sometimes cause physical trauma as well. So never assume. You endanger yourself and your patient and family by assuming things. And when you assume, you get wrong information. And I said information is power, but wrong information is not power. It can take you the wrong way. Information is power, but only the right information is power. And the biggest enemy of right information is assuming. And we as human beings have a tendency to assume. We assume a lot, and assumption is the masala in most of the movies and the scripts of most Indian soap and any soap, because people assume, then you can create situations where you get all kind of complications. So do not assume. Ask why did you say that. Ask what do you mean, and then they will tell you. To finish it off, fast history taking 2.0. We all know how to take history, just incorporating everything that we learned today, the verbal and the non-verbal. So when somebody, let's assume that you have a patient who comes into your OP, or you have gone to see a patient in the IP, first thing is greeting. Greeting involves making eye contact, smiling, and then what is culturally appropriate in your place, you can say hello, namaste, namaskaram, whatever. And then become comfortable. That means if you have gone there, pull up a chair, make yourself comfortable. If they have come to you, offer them a place, a chair to sit, make them comfortable. And start the interview with an open-ended question, never a leading question. So, so how are you? Tell me what brings you here. These are the various options that you can use. And once you have opened the interview, then it is your job to listen. Do not interrupt. There are many studies which have come up which shows that the physician interrupts their patient within 13 seconds of them opening their mouth. I'm not saying 13 minutes. I'm saying 13 seconds, 1-3. And therefore, it is very important for us to listen without interrupting. And that is not good enough. We have to encourage the patient to talk, or the person in front of us to talk. And how do you encourage? You maintain eye contact, nod your head from time to time, and make encouraging sounds like okay, or words like okay, go on, so something like that. So if you just sit without shaking your head or without making any sounds, that person may after some time may get confused or scared whether should I continue talking or not. Clarify as you go along, because you need to be correct on your information, because only correct information is power. Otherwise, you may go wrong. And don't wait for the thing to end, because by the time you may forget about this part. So clarify as you go along. Along with it, while you're trying to understand their situation, find out what they understand about their situation. What is their insight about what is happening to them? So you can ask them, what did the doctors tell you over there? What was the report say? What was there in the scan? What was there in the x-ray? What did the doctor tell you after seeing these blood results? What did the doctor tell you when they were discharging you, etc., etc. And this you'll be surprised that many times they have total blank spots. They have no idea what is going on, or sometimes they may have totally wrong idea about what is going on, and little bit of some right things that is going on, and it could be a mixture of all of that. But many a times they don't even know the name of the doctor, the speciality of the doctor, forget about what is their problem. So they have a lot of blank spots. Along with it, we all have our belief systems. Like for example, there is a belief among some sections of the patient that if you take radiation therapy, you die immediately. Now that is their belief. And that might be of great concern to them. So we need to understand that different people have different concerns. They may have concerns regarding money. They may have concerns regarding logistics. If there is nobody to come and stay in the hospital with me, then how will I manage? And and we also need to understand these concerns, because we may have the best treatment option, but if it is not practical, it is not going to get done. So therefore, it is important to understand what are the concerns from the patient side, so that we can modify our treatment from the utopian best to the most practical, because ultimately what we need to do is to get good clinical outcome, and only the practical solutions will get done, not the best solution perhaps, but the practical ones. And for that we need to find out what their concerns are, and what they bring to the table is that clarity, and we can work our management around that. When it comes to sharing information, do it in a simple language without any jargon. And we can talk about it in our next session when we talk about how to communicate bad news. When we discuss about treatment options, we are used to doing it in a medical board or a tumor board or taking cross consultations. We are used to, as healthcare professionals, taking opinion from our colleagues. What we are not used to is taking opinion from our patient and families, because we have the old style where the doctor was the king, the feudal head who says my way or the highway. And it is very important that if we can take opinion from our colleagues, because they have expertise on their domain area, and remember, the patient's life and their situation is their domain expertise. So if we talk to them that these are the things that we think will work for you, so their concerns, their beliefs, their problems, their constraints, all of that we also take into account by talking to the patient and family, just like we would talk to our colleagues, and then come to a decision by consensus. So we take decisions, the medical decision, based on the input we get from our colleagues. Then we take input from the patient and family, and thereafter we take a decision by consensus. We are often not very familiar with this concept. We don't have mentoring on this, but once we learn how to do it, it not only clears a lot of issues, because this helps us distribute the responsibility. We are not the only person who are responsible for the decision. The patient and family is also a part of the team which took this decision. Therefore, we are all accountable for it. Plus, that will be the most practical solution, because it also brings into account the constraints and everything of the patient and family. So you summarize the interview in a short way, and then you plan for the next visit or whatever you have planned for. And in the end, you close the interview. I always ask, after all the discussion, I always say, is there anything else that you want to talk about? Is there anything else? Or if I'll say, in Malayalam, I'll say, where undo. That means, is there anything else? It's a short thing, just a couple of words. And that brings a smile to the patient and the family members. It is like after you had a sumptuous meal, in the end, when you get dessert, it brings a smile to your face. Because if you may have the best meal, but without dessert, it does not feel complete. So that sweetness in the end completes our experience. So this question in the end, is there anything else? With a smile on your face, when you ask that, whatever be the discussion that happened, it might have been, there might be a lot of crying involved and etc. But in the end, you ask with a smile on your face, is there anything else? And it brings a smile to the patient and the family members. Then that is the time you should exit the room, or they should exit your consultation room. And that is the experience, that smile on their face should be the last of their experience of you. And that is the dessert that in communication we offer to them, the sweetness in the end. Many a times when we say, okay, we'll review after 1 month, many a times the patient don't know that they have the freedom to come in between if they have a problem. And how I discovered this, because I go for home care, and sometimes the patient may not be of our hospital, from other hospital, or even from our hospital, and they have an acute problem, and not a major acute problem, but still an acute problem. And I tell them, why don't you go and meet your doctor, your disease treating doctor? And they say, but they have asked us to come after 3 weeks. But I said, but this problem of yours started since 2 days, so why do you want to delay it till 3 weeks? And they said, so can we go tomorrow? So of course. So many times, even though it sounds like common sense to us in the healthcare sector, that if you have a acute problem, you come early, But many a times the patient and families, they are not able to think along those lines. So in my practice, what I'm started doing is I tell them, okay, review after 2 weeks. I tell them, if there is any problem, you don't have to wait for 2 weeks, you come early. I have also started writing in the prescription, review to 2 weeks, report early if needed. These are some changes that with experience I have incorporated. It's always a constant improvement on what you have been doing. So to end, last thing, again, you start with a greeting, you finish with a greeting, and the end greeting is I make eye contact, smile. If required, you say something what is culturally appropriate in your area. In my case, I always say apasheri. That means okay, fine. So okay, bye. So that is something that I do. So last slide. Uh, all of this that we have talked about today is about making the patient and family feel that we care for them. That feeling is what empathy is. That feeling is empathy, and you cannot define it, but you can feel it, you can experience it. And that is what enhances the satisfaction. That is what enhances compliance, clinical outcome. It improves our quality of life in many, many ways. It keeps us safe. So this experience of empathy comes when you practice active listening skills. And you may have many degrees behind you. Your hospital may have 5-star, provisions. You may have machines worth crores of rupees. But ultimately, what patient and families remember is how they were made to feel. They'll remember how you made them feel. And that, depending on that, if they felt that they were cared for, if they felt that the experience was positive, satisfactory, who knows, they may go and tell a couple of people that, we went to this hospital, we met this doctor, it was a great experience. However, if the experience was opposite of that, they will go and tell everybody in the world that, that hospital is a, bad place, that doctor is not good, those people are bad, all kind of things. So our effort should be to create an empathetic experience for the patient and family by practicing active listening skills. And some cliche sentences in the last, you have one mouth and 2 ears, so listen more and speak less. But simple thing is, explore more of the body language. Go to Google, go to YouTube. You have plenty of things available, and practice this. So I think I've already taken a lot of time, but I'm happy to stay back longer for questions. I don't mind staying in, as long as required. I'll stop here. Thank you.
Thank you so much, sir. I guess there will be a lot of questions, but can we quickly move on to the case presentation and take the questions together, sir, after that?
You know what, Sridevi, I totally forgot that there was a case
No
presentation.
problem. No problem, sir. No problem. It was very useful information, so I didn't want to interrupt also. So we will take up the case presentation, and while during that time you can type your questions in the chat also, and then we'll take up the discussion together in the end. I think Dr. is going to present, Dr. Chandramukhi. She is not well, so I would like someone to volunteer to read the case presentation.
Hello.
Yes, ma'am. Are you able to read?
I think I can. I have a bit of
Okay.
cough, but I guess I can go
Sure.
ahead.
That should be great.
I'm audible,
ma'am.
and I'm having a problem with the internet connectivity today because there's been a storm over here in Delhi. So I hope I don't get
disconnected. We can hear you, ma'am.
Yeah. So this is a patient, a male patient, 84 years old, and who had been diagnosed of non-Hodgkin's lymphoma, grade 4. So the presenting complaints of the patient were feeling of a small hard nodule below the left mandible, since last 2 months, and now this was beginning to pain sometimes while he would touch. So that had been for the last 1 week. So history of illness, patient had no significant complaints except for the feeling of the nodule in the neck, which was now paining. He was very anxious about this. On examination, it revealed a small 1 by 1 centimeter tender, round, mobile hard swelling in the left submandibular region. The palpable lymph nodes in bilateral inguinal area were there. Cervical and axillary lymphadenopathy could not be appreciated. His general physical examination was good and all his vitals were normal. On examination, chest, CVS, they were all normal. So regarding treatment and significant investigations, all the routine blood and urine investigations were normal. The FNSE for this submandibular nodule was done, and this showed high-grade malignancy, which was a non-Hodgkin's type lymphoma. So after this, a PET scan was done, which revealed a grade 4 disease. And this was followed by 8 cycles of chemotherapy that were like R-CHOP, they say. R-CHOP were given, 8 cycles of R-CHOP were given. So there was a big psychological aspect. So what were the psychological aspects for this patient? First of all, apart from the age that he was in, he had deep anxiety. And this patient had deep anxiety, and his family, regarding the diagnosis, because such an old patient now having a grade 4 metastatic disease and revealing them about the severity of the disease, that was becoming a problem. And like, now what are the treatment options for this, and what will be the outcomes? He being so old, will he be able to undergo so many cycles of chemotherapy? So they were very anxious, like, how will it go about, and what will be the outcomes? Will it be effective or not? So all those things were a great concern. So, like, as I said, the challenges of the tolerance of chemotherapy at his age. So another thing was that the patient is a highly educated professor. So he understands, he's aware of what this disease is about, and most of the patients already know. They keep hearing, like, this person had cancer, this treatment was given, so this happened to him, the patient was feeling unwell, and all those sort of, because they do talk to other peer groups and the family people. So there's a lot of anxiety whenever such kind of a diagnosis comes in. So this patient, since he's a highly educated professor, but he's dependent on his son and daughter-in-law, who are both working. So another anxiety also settles in, like, okay, how will all the chemotherapy cycles will be managed? Who will take me? Who will stay with me? Who will handle all the problems for me? Diagnosis of he having this malignancy, it shook him, especially after 8 years of handling his wife's illness, who also suffered from CA esophagus for so many years. Like, he had seen that his wife, all those challenges that she had undergone, despite being a patient of cancer esophagus, who had undergone surgery, and then later on all the other complications with chemotherapy, the radiation therapy, and then being on rice tube for almost practically a year. So there was so much of anxiety in this patient regarding now what will happen to him. So malignancy related trauma and the memories hurted him very deeply, and he too assumed that his journey will also take the same course of difficulty. Next. So the medications, as I told earlier, were the 8 cycles of chemotherapy. That was the R-CHOP regime that was followed. They were given over a span of almost 8 months, along with various supplements to reduce the chemotherapy-related side effects and for general well-being of the patient. So now the main concerns, as I already did mention in the psychological aspect, which are very, very important, is like how to communicate and reveal the diagnosis of a challenging and a life-threatening illness to the patient and the relatives. For every patient, any kind of a diagnosis is new, and it really affects the patient. And especially when they hear that it's a malignancy, it really it just shocks them down. So now again, next is now how to communicate, that how he has to cope up with the challenges of chemotherapy. That's also very important. Apart from telling about the diagnosis, then also how he has to undergo the chemotherapy, what all challenges will he face, what all he has to do, how he has to cope up while undergoing chemotherapy, which goes on practically for almost 8 to 10 months, because at times the sessions are also stopped because of patient not being too well in between, patient losing appetite, not being stable for giving other sessions of chemotherapy. So everything was discussed with the patient and the relatives. Now, how to sort and answer the questions related to the fear of recurrence of illness, even after the treatment. I mean, very first question after you explain everything, the patient or the relatives, they'll always ask, Doctor, what next? Will we have a recurrence? After how many years? How many days? So those are very, very practical, every time questions that are asked by the patient himself, especially now, because patients are aware and educated. So, summary, patient is an elderly male having diagnosed with NHL grade 4 carcinoma, having undergone all cycles of chemotherapy very well, with very positive note. So there was a very good patient support along with the family and the entire medical team. So the discussion points, how to communicate to the patient and a family. So this is very important, as Sir has been telling, in his lecture, which is so beautiful. How to counsel a patient who has already witnessed trauma of a life-threatening terminal illness of his or her own spouse or any near and dear one. How to answer their queries and fears so that they maintain positivity during the long course of treatment. Why should I take treatment if I may have a recurrence, oblique, all the side effects due to the treatment itself? So all these questions, they need to be answered to the patient, especially when he asks. And I feel they should be told, as Sir said, you should give them hope, the realistic hope. That's really important. And that was done in this case. Everything was explained to the patient, to the relatives, so that the patient could, give a consensus about whether, what will be the side effects of the chemotherapy, the patient asked. So whether he is willing to go through the treatment, all these cycles. So yeah, and the patient took a bold step after discussing with the entire team. The doctor and the staff made him so comfortable, discussed everything with him and the family, so that he was able to come to a conclusion that yes, I am ready for the treatment. So that brought in him, apart from the anxiety that he was having, yes, he did get a ray of hope of undergoing the entire cycles of chemotherapy. So that's how you communicate to the patient. I think that's really very important. Yeah, thank you.
Thank you, ma'am, for bringing in the presentation. In the interest of time, because we have to start the next session at 7, I'll go directly to Dr. Biju for his comments. So sorry that I couldn't ask the participants, because we have to rush to the next session at 7.
But I think we still have some time before the 7 p.m. deadline. I would be really happy if you could give some time to the participants to put their views into, at least on the discussion
Sure,
points.
Yes, sir. Sure, sure, sir.
Or at least give them a chance if they have any questions to ask regarding the session that we had. Maybe, just 5 minutes.
Sure, sir.
Sir,
Yes, sir.
I have a request. Can your presentation, can I use it in my hospital to show to the staff and the doctors, like how, the important things that you shared with us today? Is it fine enough?
Absolutely, absolutely. Be my guest.
Thank you.
Most welcome.
Just give me a minute. I think this battery is running low. I'll just go and switch on this thing. 1 second.
Sure. Just from my experience, when we use Dr. Biju's slide, it will be very different when we take sessions. So you can use we'll be sharing the YouTube link of the session. So some of the teachers, they use Dr. Biju's video lecture. That will be more easy if you would like to, because anyway, we'll be sharing the video. So you can use it as a teaching material in your place.
I
We'll be
had a
sharing
small
the
comment
presentation
to
also.
make, if I
Yes,
may
please.
sorry.
Sure, sure.
I'm not sure what the experience of the expert is in regions where the patient's family or public in general expect the doctors to have an overbearing persona and dictate what is going to happen to the patient. And in fact, not just patients and general public, but also the work colleagues and staff around. And any doctor who is not who is the way we expect them to be able to give complete care, they're considered as maybe doesn't know their job, is just trying to sweet talk the patient because they can't cure them. So how are we? So I mean, one does navigate this, but are there any really tips or how a change can be brought about with this? Although there has been some success with some patients, but most of the times, and also patients' attendants don't want the patient to know that he or she has sorry, cancer. So the first thing that they would want to maybe come and enter the room and say, don't tell the patient what she has or he has. How do we navigate this? If there are any tips, sir. Thank you.
Thank you, Priyanka, for that. Regarding the family not wanting the patient to know, we will deal with that in the next session. That is day after tomorrow, I think. So I'm not going there. Regarding the family or the patient wanting an overbearing presence of the doctor in guiding them and telling them what to do, I think the right terminology might be that we have to inspire confidence, not fear and terror. But many times I have seen, unfortunately, some of my colleagues taking great vicarious pleasure in saying my patients are terrified of me. I would rather somebody say that my patients have great confidence in me. And it's a thin line. It is a thin line between an elder brother and a tyrant, or a somebody in authority. So I'm not saying don't appear authoritative, appear confident. And you may have the knowledge, you may have the skills, but appearing confident in your overall persona, your good communication skills enhances that. Also, somewhere along the line, I think it may not be true for most of us, but at least some of us, we have become prescription vending machines or procedure technologists. And we have forgotten our role that a doctor has to be a friend, guide, and a philosopher to the patient and family. And that includes telling them and guiding them with inspiring confidence within us, in their minds and their hearts. But I wouldn't go, we should be inspiring terror and be overbearing in our persona. You should dress smart, and whatever is acceptable culturally, you should have a personality, and do that. When you're discussing something, there is, discuss it seriously, but starting point, ending point, the smile on your face does not diminishes you in any way. It only enhances.
Thank you so much, sir. Thank you.
Okay.
Any questions?
Yeah.
Sorry, sir.
No problem. I was just wondering whether any of our co-panelists who have any thoughts on the discussion points. How to communicate to patient and family is very generic, but I find that this how to counsel a patient who has already witnessed a trauma That I find that it has more substance to it. Would anybody like to, take that on? Okay, because time is in short supply, I just put in my 2 words of thought into it, 2 pennies worth of thought into it. It is not just, we can segment our interaction, relationship building with our patient and family, but specifically coming to that point, let me see. Yeah, who has witnessed trauma of a life-threatening terminal illness of his or her own spouse. Now, I have had occasions where I have to deal with exactly the same kind of things. And apart from the general things that we talked about today about building up a relationship and, giving a sense of empathy in our overall, our attitude, in our body language and the words that we use, that we are there to care for them, we care for them, we care about them. All of that is there, but specifically in during our conversation, I would perhaps ask this person who has lost a spouse, how long that was, what under what circumstances all of this happened. And people are usually happy to share their experiences. We went to this hospital, they diagnosed this, and we took this treatment, and that happened, and this happened, and they're happy to share. And then usually when they tell that the final person finally died, and usually then how did you deal with it, then they talk about how they felt about it, and ask them how did the other family member cope with it, and then I ask them how did you cope with it, and then they tell about that part. So basically just brings out a lot of things. Then I also ask them, so what are the good memories you have of your spouse, what are the things that brings a smile on your face when you think. So then they talk about, we went to this place and this happened, and while they're recounting it, an actual smile comes into their face. So there's a positive energy that comes in. Then I asked them, so what were, what are the concerns that you, since you know that you have a similar kind of a disease or another disease which is equally not so great. So based on your experiences, not so great experiences that your spouse had, what are your thoughts about yourself? What are your concerns? What do you have any concerns about this thing? And then people say, I'm see, many times when people say, doctor, I'm not worried about dying, but I don't want to experience this that my husband had or wife had experienced. I don't want to experience this thing. And it could be anything. It could be the physical experience, it could be the sense of how people came and made a nuisance of themselves, or how at night time the nurses would come and start a drip, and it would interrupt their sleep, or this constant poking for a vein. And it could be so many different things, but we will get to know only if we talk about it. So while having this conversation, we also talk about the good things and the not so great things and what their concerns were. And then we say, okay, so now I have information, and that information is power. And then I can tell them, okay, so these are the real things. I'll make instruction that, no drip at night. So only drip, will make sure that you get drip 9 a.m. to 9 p.m. After that, I'll make sure I'll write it, and I'll give an instruction to the nurses that you are not to be disturbed during nighttime with a drip. And regarding sponging, don't come at 4 a.m. to do sponging. So I tell them, the nurses, if you have a end of life care center, if you have a hospice care, then definitely it becomes easier. But if not, at least you can tell the nursing staff over there that please make sure that you are not knocking at the patient's door at 4 a.m. to give sponging. It's a fairly sick patient. Let her be comfortable, let him be comfortable. So there are a lot of small things you can incorporate that enhances and reduce, and basically their experience of their own terminality will be very different and hopefully positive than what they witnessed with their near and dear one. It could not just be spouse, it could be their parents who died with a lot of suffering, and they have this in their own mind that will I also be experiencing all of that, this unnecessary pushing them into ICU to critical care. So all of that, and we can counsel the family members to protect the terminally ill patient from critical care, because a terminally ill patient, and there's a whole counseling session for that we can't incorporate here, but there are a lot of ways, and making sure that we understand the concerns of the patient and making sure that we put in place the things so that those concerns are addressed. So that is my take on that. And it kind of also incorporates the third question. If anybody has any comments on that, I'll be happy to respond. I'm sorry, I can't throw my voice. I'm not really, voice is not up to mark today.
Any comments from the participants? Or any questions that you want to ask? I can't see any response. If you have anything unanswered, just message in the WhatsApp group or send us an email. We'll be getting back to you with things from the experts, if that is okay. Sorry to rush you through the interaction, sir. So sorry.
I think I'm mostly to be blamed for that, for
No,
not keeping the timings in head. And
no, sir, no. It was a great learning. So,
and thank you all for your kind comments. These are spiritual energy, positive energy that you're giving me. So even though health-wise I'm not up to mark, I'm feeling much better at the end of the session, energy-wise.
thank you so much, sir. Thank you so much, sir, for taking the session, even though you were unwell. I think everyone is affected with cold and cough. That's why I was speaking very less. So we'll see you all for the next session with more learnings about communication, how to communicate, dealing with difficult situations that you have been asking in many sessions. Thank you so much, sir. And thank you so much, all the participants. And thank you, Dr. Chandramukhi, for bringing in the presentation and presenting it for the group today. Thank you so much.